To all who are new here, welcome to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our upcoming schedules, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. An article related to today's talk is available for download from the dashboard. The recording will be available for review from our website tomorrow. Dr. Jassal graduated Magna Cum Laude from Ross University of Medicine and was elected by his fellow residents in the Departmental Faculty as Chief Resident at Hofstra Northwell Health. He continued his pain fellowship at the University of South Florida. He currently serves as Assistant Clinical Professor for the Pain Medicine Fellowship at the University of South Florida and the Assistant Professor for the Department of Physical Medicine and Rehabilitation at the University of Central Florida. He has authored numerous original articles, abstracts in peer-reviewed journals, and several textbook chapters. He is speaking today about sacroiliac joint pain. So I'll let you take it away.
Thank you so much. What a pleasure, and I thank you so much to my colleague for inviting me here today. So what I do realize is that there's a broad spectrum of people in the audience who are going to listen to this lecture. From what I understand, there's anywhere from athletic trainers, a ton of you guys out there and gals, and there's physical therapists as well as physicians as well, and some students. So I look forward to keeping this lecture sort of appropriate and on task for everyone out there so we can all learn something. Appreciate that kind introduction. So today we're going to talk a little bit about the evolution of sacroiliac joint pain, as well as some of the interventional treatment options available for those types of patients. I myself am a board certified physical medicine rehabilitation doctor. So I've worked very closely with both athletic trainers, physical therapists, occupational therapists, sports medicine specialists, and then I've also subspecialized in interventional pain management, and now do a fair share of my work practicing really good musculoskeletal as well as interventional pain needs for the community. I do want to bring about my conflicts of interest. I actually have none for the presentation today, but I served as a consultant currently, as well as on the advisory board for a numerous number of device companies, both in the neuromodulation space, as well as the minimally invasive spine space, as well as the minimally invasive SI joint fusion space. For the purpose of this talk, I will not mention any brand names or any branded sort of devices. We're just going to broadly talk about the overview of sacroiliitis and some of the treatment options today. So let's jump right in, and I'll try to make sure that we keep on task because we have about 45 minutes to make this a very instructive period of time for you. Let's start a little bit about SI joint anatomy and some physiology. I'll be discussing primarily diagnosing SI joint dysfunction because I think it's very important for us, as you know, that chronic low back pain or even acute low back pain is complex, and there can be a series or multiple pathologies that can contribute to chronic lower back pain or acute low back pain, and it's very important to get your hands on the patient, talk to the patient, and get a good history and physical examination so that you can come to the right diagnosis to come for the right treatment options for these patients. So we'll spend a great deal of our talk today talking about diagnoses. We'll talk about the broad overview of the treatment options. You know, besides the conservative options, which I think are fantastic options that should always be tried first and primarily with the non-steroidals, skeletal muscle relaxants, physical therapy, and a good structured course of physical therapy. If those patients are not doing well with sacroiliitis and now it turns into a chronic phase, there are things that we can do such as injections, regenerative medicine. There's something called radiofrequency ablation, which we'll talk about more in detail, as well as modulating the nervous system, which if you're unfamiliar with it, we talk a little bit about this in regards to placing some sort of electrical stimulation current with a implantable system, and that's something to help modulate the nervous system for disrupting the pain pathway. And then we'll talk about the evolution of the last case resort, which is fusion. And fusion has always been sort of an open approach. And whenever anyone hears fusion, we think of course, last case resort. You want to make sure you keep people mobilized as opposed to immobilized. But there are some novel approaches that I do want to bring up today so that we can break some barriers of some of the thought process of the negative parts of lateral and maybe open fusions that are much more invasive, and some of these newer approach. We'll talk about the evidence based on each one of these today. So let's dive right in. Let's talk about anatomy. So the SI joint is a loading joint. It's actually one of the largest joints in your body, and it makes up of the sacrum, which is your coccyx or tailbone, and your lumbar spine. Your lumbar spine sits right above that. Of course, there's the L5 that articulates with the sacrum 1. And you have these two larger iliac crests that shear off onto both sides on the right and left. If you sort of palpate, sort of a bump or a bony prominence on both sides of the lower belt line, right below the belt line, you can feel the posterior superior iliac crest, or the PSIS as you know it. And then, of course, in between the sacrum and the ilium makes up the composite joint of the sacroiliac joint. So we're going to be focusing on that joint. Of course, there is a left side and there is a right side to this joint. Realize that a certain degree of range of motion and movement in that joint is normal, but for the most part, the SI joint is going to support your upper body weight and it's going to absorb the impact from the ground. So it's meant to be really, sort of a fixated joint with some minimal movement or some minimal range of movement or motion. However, when this motion gets to be repetitive and there's repetitive sort of micro trauma to the SI joint, or if there's hypermobility to the joint, or if patients have, sort of trauma or sports-related injuries, maybe even prior fractures to the area, patients have sort of prior fusions to the area above the site of the SI joint. They can have hypermobility to the SI joint from stress and strain. Those are patients that will have these issues of sacroiliitis that may be non-responsive to conservative care. The normal anatomy is going to consist of many different types of ligaments. So from a pictorial view, this is one of those pictures. Notice that there is the sacroiliac joint ligaments on the posterior, the outside aspect. If you're looking from the inside, from the bladder outwards, you're going to have sort of the iliolumbar ligaments that attach from the L4 and the L5 spinous process or transverse process, and then they attach over to the iliac crest. And then there's the sacrospinous and sacrotubeus ligaments. So here are some sort of the anatomies here. These are here for your reference, and you can take a look at them later. It's important to also mention muscles and muscle attachment sites. I think this is important as well because, when you're trying to rule out other types of pathologies that can contribute to low back pain besides sacroiliitis, one must think about the piriformis, because patients can interact or present with piriformis syndrome that can also present with low back pain and even sciatica-like symptoms with impingement of the sciatic nerve, depending on how it traverses or goes under or between the piriformis muscle. I think it's also important to note the hip joint and where the hip joint is located in location to the SI joint as well, because hip joint pain can oftentimes be pain worse with loading as the patient is standing or walking. They can oftentimes have pain into the groin area as well as into the anterior thigh to the level of the knee. So if you're starting to hear these types of telltale symptoms, especially with an older patient, if you're suspecting osteoarthritis, or even in a younger patient with trauma to their hip joint, prior, realize that can sometimes also overlap with the pain symptoms for sacroiliitis. And we'll talk a little bit more about the symptoms of sacroiliitis, but I want you to be aware of how close that anatomy is from the hip to the sacroiliac joint. And then realize the lumbar attachment sites. There is the multifidi muscle, so patients can have myofascial or muscular pain from their low back that can broadly go upper, superior, and as well as inferior to the SI joint. And then there's the deeper muscles of the quadratus lumborum as well that are both on the right and left. So realize it's complex, and there's a lot of muscles that can also be potentially causative factors for myofascial pain that can contribute to things that present such as sacroiliitis but may not be sacroiliitis. The vasculature, even though anatomy is so far past us, it's always great to have a good little review. Realize the critical structures. The critical structures are going to be the superior and the inferior gluteal artery. So it is vascular in that area, depending on if you're coming off to the side of the sacroiliac joint. And realize that any pelvis trauma can contribute to vascular injury as well. So important to note, and we'll talk a little bit about what this is important for later as we talk about interventional treatment options. This slide really talks about the innervation, or what is the nerve supplies that supply the SI joint. So whenever we're talking about pain, we want to know that there's a particular nerve supply that causes pain. And if there is no nerve supply, we're not so concerned with the amount of pain or sensory stimulation or aberrant sensory stimulation like painful nociceptive pain unless it has a nerve supply. So just realize from this, at the upper part of your sacrum, there are nerves that come from the L5 medial branch nerve, as well as from the sacral nerves on the lateral branches at S1, S2, and S3. So that's where those three needle configurations are on that model on the far left on your PowerPoint screen image. It shows that there's an S1, an S2, and an S3 nerve. And then you can see the nerves coming from the above picture that are from the L5. So this will really have a lot on treatment options, whether we're talking about injections, cauterizing the nerves called radiofrequency ablation, and even other treatment options that we'll mention later. So let's talk about the meat and bones of this PowerPoint. We're going to talk about diagnosis, because that's the most important part. If you can't diagnose the patient appropriately, you really can't offer them a treatment, or the patient will be unfortunately lost in a limbo of treatment options that may not address their problem. And this goes even with simplistically diagnosing the problem to make sure that the patient has a structured physical therapy program for sacroiliitis as opposed to spinal stenosis or piriformis syndrome or hip pathology. You really got to get to the root of the diagnosis to make sure that their treatment is structured and focused. So it always starts with a comprehensive history and physical examination, and really depends on their musculoskeletal symptoms. It's critical and it's complex. So it really just starts when the patient walks into the room. A lot of times you can notice their gait and see the way they walk. Antalgic gait has a lot to do with, it tells us a lot about the patient and how they offload the area. You can tell a lot about whether they have muscular sort of weakness, like gluteus medius weakness. You can tell a lot from their gait. So I think that's really the first and primary starting point. Talking about history, of course, from a pain perspective, we all know about OPQRST. When did it start? What does the pain feel like? Is it dull, achy, deep, sharp, or is it more like neuropathic pain that is more like sharp, shooting, electrical, burning, numbness, tingling? And sometimes there's quite frankly an overlap of these symptoms. What makes it better? What makes it worse? S, how severe can it be on a scale of 1 to 10? the timing, does it come and go? Does it wax and wane? Is it chronic? Is it constant? Does it hurt more with standing, sitting, etc.? So a lot of these can really tell you, what the patient is sort of describing. And I don't know if we mentioned quality, but quality is important as well. So these really help rule in and rule out sort of diagnoses. So talking about SI joint dysfunction specifically, one would notice pain mostly with transitional types of exercises. So patients will oftentimes say, doc, I just can't get comfortable. My pain is worse with, sitting to standing or, getting my day started. It feels, worse in a particular area of my low back underneath my belt line. It may radiate into certain aspects, which we'll talk about the referral pattern of how that is in the next few slides. But even the referral pattern can be quite complex. Does it travel into the buttocks? Does it travel into the groin? Does it even go down the leg into the foot? We think of sciatica commonly from an impinged L5 or a lumbar nerve root, like radiculopathy being the source of pain that shoots down to the leg. But can SI joint pain refer to that, and how often? And it can, although rare, it can even up to 20% of the time, and we'll talk about that in the next few slides. But again, ruling out other sources of low back pain. From an athletic component or an athlete component, lumbar sprain strain issues, myofascial pain. Talking about a little deeper from the joint structure, can it be coming from the lumbar facet structures? Could it be discogenic? Could the patient present with a herniated disc from in athletic injury? Hip pathology, as we mentioned, in piriformis syndrome. So it's critical and complex, to say the least. When making the diagnoses, I think it's really critical to see the way the pain referral patterns can spread. And just to be comprehensive, I've mentioned 3 studies, for your reference: Fortin et al., Slipman et al., and Cohen et al. And really it just describes, but if we were to talk and generalize the way pain travels from SI joint pathology, really it comes down from the posterior back. I usually ask my patient, is it above or below your belt line? And if it presents at the belt line or even slightly below, I'm thinking the sacroiliac joint. And oftentimes they'll kind of point and have some, finger, sort of focal tenderness right at one area on either the right or left, or even both sides. And the pain can oftentimes, travel into the posterior buttock, and it can radiate even into the upper thigh. And so generally, those are the radiation patterns from that picture. Keep in mind that some people are outliers and they go into the groin, which is, I think, sometimes more representative of hip pathology. If you imagine where the hip joint was and how the acetabular and the femur sort of interact, the pain can radiate into the groin area from hip pathology. But realize this can happen with some fair share cases for your people with sacroiliitis. And realize it can even radiate into the upper abdomen. It can radiate into, the lower abdomen, the lumbar or the low back region. And it can sometimes go down to the knee or even to the foot, like we mentioned earlier. So don't disregard the patients who, maybe your athletes, like your weekend warriors or your runners. Patients with repetitive microtrauma to the SI joint because of maybe running, with maybe an associated fall. They could even have, a large L4-5 extruded disc, but quite frankly, they don't really have neuropathic pain or sciatica or radicular pain symptoms down the leg. And they may even had, a discectomy or a laminectomy, and without any sort of relief to the area of their sciatica. But quite frankly, they could have and be presenting with sacroiliitis. So I really want this to be high on your radar, because obviously, low back pain is hard to treat. So we have to treat these patients with a great history and physical examination to start off with. So again, some of the clinical features just to review. Some bullet points: lower back pain below the belt line or below the L5, oftentimes presents with pelvic or buttock pain. They can present with hip, groin, or posterior lateral thigh pain. They can present with pain, numbness, tingling, or even weakness. Most of the times it is unilateral, but sometimes, occasionally, it can present bilaterally. I oftentimes realize that if you treat the most symptomatic side first, oftentimes that'll resolve the contralateral aspect as well, or the opposite side. They can feel sort of subjective leg instability or buckling, and obviously they're just very uncomfortable. So oftentimes they'll be kind of shimmying in their chair when they see you, you know, in your office. And really those exacerbations with transitional activities like we talked about, sit to stand, climbing upstairs, those things are going to really hurt these patients. Further diagnosis is made by physical exams. We talked a little bit about, you know, what do we see subjectively from the patient's words, from a history. You know, talking a little bit more in detail, we have to put our hands on the patient and diagnose the problem with a physical examination. There's a long list of physical examination techniques on the right side. You know, pick 3 or 4 that you feel comfortable with, do them on every single patient, and see that you make sure you get good at those. And so, you know, my going tests are finger Fortin tests on the very bottom of the list, which is literally just point tenderness over the SI joint, whether it's right or left side that they're complaining of. I oftentimes use this Patrick or Faber test, F-A-B-E-R. Very easy to remember because the acronym of the letters of the name imply exactly what you're doing for the test. F is flexion, abduction, AB, external rotation. So you're going to have the patient place their foot on their contralateral knee, and you're going to have them push down, or you can push them down on the ipsilateral aspect of where their SI joint hurts, and that's called flexion, abduction, external rotation. If that hurts their SI joint, you know, there might be a chance that it could be coming from the sacroiliac joint. Compression test is another easy one I do. Just as the name implies, you're going to put your hands on both sides of the iliac crest, and you're going to actually compress the areas. By compressing the areas, you're really going to kind of put pressure and offer pressure from the iliac bones into the sacrum and force pressure into the sacroiliac joint. And as the name implies, it should provoke some sort of or some degree of pain into the area of the SI joint. I like Gainslin's test, but there's a number of other ones out there. But you know, I would always say pick 3 plus a finger Fortin test. And if you do that, it really will increase the sensitivity and specificity to almost 90%. And that's important because you want to make sure that you're coming to the right diagnosis. And that combination of tests is really going to increase the chance of you making the right diagnosis. Realize that imaging helps to a certain degree. You can do MRIs, you can do X-rays. Of course, X-rays would always be a starting point before you get into the MRI or CAT scan range. But you know, when it comes down to it, those types of imaging studies are really going to help rule out other diagnoses. They're going to help make sure there's no herniated disc that's causing sciatica or lumbar radiculopathy. They're going to make sure that you don't have hip pathology, as we talked about earlier. So they're going to help you rule out other types of pathology, but it's really not going to necessarily help you come to a diagnosis of sacroiliac joint pain or sacroiliitis. If you are absolutely suspicious from a history and a physical examination technique or aspect of your diagnoses, really the only way and the one thing that we have from a diagnostic standpoint in all of interventional pain is actually an injection. If you can do a diagnostic injection into the sacroiliac joint, and actually if you do it twice, there is an extremely high likelihood for a very specific result that the patient has sacroiliitis. And in fact, if you are thinking of anything surgical, oftentimes I'll have even surgical referrals prior to doing even you know, a lateral approach fusion from our surgical colleagues like our neurosurgeons or orthopedic surgeons to really make sure that the diagnosis is coming from the SI joint. And we'll talk a little bit about what that entails later in the presentation. And actually, that's right now. So if we're going to do a sacroiliac joint injection to diagnose and also treat the problem, we talked about the sacrum and the iliac crest coming together. And when they come together, they form a nice, you know, sort of river view, as we call it, joint. Just like as you would imagine, everyone knows what a knee joint looks like. you know how you have the knuckle of the tibial plateau meeting the actual distal end of the femur, and those articulate into sort of a joint, and that joint complex can be the same joint complex if you think about it as an SI joint. It's just a lot larger. And so what we try to do is, just like we place steroid or intra-articular steroid injections into a knee joint or a shoulder joint, we're going to do the same into a sacroiliac joint to make the diagnosis. And so commonly I'll inject 2 or 3 cc's of Marcaine, a long-acting anesthetic, and sometimes I'll mix it in with a little bit of steroid for some long-term treatment if we're doing it for a therapeutic or a treatment injection, as opposed to just diagnostic criteria. When we do the injection, it's very important to mention that we should do this under some sort of imaging guidance. And so there are 2 types of imaging guidance that we use in the interventional pain space, or when we do musculoskeletal injections. A lot of you will understand and realize that ultrasound is something that is just so commonplace now. It's just so incredibly versatile. I know even in my office, I have a small one that connects onto my my iPad or even my iPhone, quite frankly, as well, and it's versatile. I can take it anywhere. But in my office, I actually still rely on fluoroscopy, which is a mobile C-arm X-ray, and the X-ray itself allows me to really kind of make a nice sort of angulation on the X-ray so that I can look right into the joint and really guide the medication in there. And I can use a little bit of contrast dye so that we can place the medication in there. Realize that there are differences between what we call a blind, if you don't use any sort of imaging, versus ultrasound versus fluoro injections. And although ultrasound is very handy, there's a great degree of accuracy that can be either not as accurate or very highly accurate. And so I think it's something to be aware of, but I think we're all sort of getting better at our musculoskeletal ultrasound skills, but also a lot of our patients do have sometimes more tissue in the area, which makes it very hard to visualize via ultrasound as simply as you would with a peripheral joint such as a knee or a shoulder injection when you're trying to utilize ultrasound for those. So really my go-to has been fluoroscopy or X-ray guidance into the joint, and realize we can do either a joint injection into the joint or kind of around the joint or in or around the joint. And so typically what I do in my practice is I try to put the medication in and around the joint because it offers more pain relief from a treatment and a diagnostic point of view. So this will kind of show you the actual pictures of what we're looking for under an X-ray image when we see this patient in office. And as we mentioned before, you remember we talked about that river view. I want to line up that really nice river view. And of course, there's the sacrum. And again, there's that iliac crest. You can see the river, and we just target the sort of bottom aspect. That's why the needle is coming from the bottom to the top. And you can see a little bit of a black line, or that linear black line that's filling up that that joint space, and that proves that you're truly in the joint, and making sure that you're in there. And it's a very simple, 5-minute injection. A lot of times it's done really under local, anesthetic, and the patient notices response right afterwards. We give them sort of a pain journal to really document how they do in terms of their pain relief, because I want to make sure for the first 6 to 8 hours, especially 6 hours with the Marcaine, that they're doing very well. So it offers, not only just treatment, but also diagnostic value for our patients with this SI joint pain syndrome. We talked a little bit about the anesthetic. We obviously want to use contrast. Contrast is important. We try to keep low volume just because you don't want to make sure this medication spills into other areas, because then sometimes it can treat other things like muscular pain, for which we do trigger point injections with for myofascial pain. So you want to make sure that you're really getting the diagnosis correctly. Everyone, has heard about regenerative medicine. Stem cells is a very, very hot topic. Realize that we can talk about stem cells, sort of briefly into 2 categories. and this is a very brief introduction for stem cells, or regenerative medicine. We can do platelet-rich type of plasma injections or mesenchymal stem cells. And broadly, if you're trying to sort of decipher the two, realize that PRP is obviously removing the patient's own blood, centrifuging the whole blood, and really taking out what you really need to help decrease the inflammation, increase the blood flow, and most importantly, improve the tissue growth and improve healing. And so we look for growth factors when we put it in a centrifuge, things like, IFG1, PDGF, all the lists that are written there. And so we're looking to see that we're offering, decrease in inflammatory response and improvement in certain types of healing for that local area. For mesenchymal stem cells, and they can come from, really harvested from two areas, whether it's your bone marrow, whether it's the iliac crest, we can take a sample or a biopsy from the crest and manipulate that tissue to inject certain types of the rich content of those into the joint, or we can do the same thing and get it from the patient's fat. So we can harvest cells from the adipose or fat cells. And so those are two ways to offer them treatment options from regenerative medicine or stem cell like therapy. I think this is extremely important when really looking more at the athletic population as opposed to some of our, chronic degenerative osteoarthritis older patient populations. Unfortunately, also keep in mind, we'll talk about, evidence right now, but, realize that these things are going to usually be non-covered items. Injections that we talked about, like intra-articular steroid injections, can be covered by commercial insurances, Medicare recipients, Medicaid recipients even. But, when we're talking about, PRP or mesenchymal stem cells, these are going to be things that are more out of pocket. And so we want to be very, selective and make sure we are very honest with our patients if they're potentially appropriate candidates for these types of therapy. Here's some studies to mention. I wish these studies were, a larger sample size, but realize there are some studies out there. There's 3 that I put in here, but you realize the bottom 2 are case series, so they're lower quality studies. Not to say that they're not good, but there is the one on the top is a prospective, randomized, open, blinded endpoint study. So, from just knowledge base, when you're looking at studies, if something is a smaller sample size, obviously, it's a great starting point, but you want to start examining whether this is reproducible in a very large sample size or in multiple centers in a forward fashion, as opposed to looking at your data in a retrospective or a sort of a behind fashion. So it's always better to get a prospective, forward studied, randomized, meaning it's you're randomizing the patient into some sort of placebo group or control arm versus the treatment arm. And it's really great if you can have them cross over in the study so you can make sure that the results were truly brilliant results. And of course, you want it to be multi-center, so to make sure that you're not cherry picking populations in one particular area. As far as I know, we obviously need more for this out there, but hopefully as time goes on, we'll be able to study this further. So we talked a little bit about injections, whether it's through steroids, which has some good quality evidence to know that it works for patients. We talked a little bit about regenerative therapy options, which might be a fit for maybe some of our athletic population of patients, but realize that you got to be careful about how you talk to these patients about evidence, because realize that our evidence is growing for these things, and really we don't have a full body of evidence for regenerative medicine just yet. But there are other options out there for patients that do have good quality evidence as well. And so we'll kind of browse this as well over the next few minutes. So we talked a little bit about the nerve supply to the joints earlier. Remember, we mentioned those 3 nerves that come from S1, S2, S3, like that picture shows on the right screen, as well as the top nerve from the lumbar 5. So the concept, which is interesting, is, well, instead of injecting medication into the joint, let's say they have short-term pain relief, injecting medication into the joint, what if we inject medication to the nerves that supply the joint and we block those nerves? That's called a nerve block, as we all know. We do this for the low back, we do this for the neck. Why not utilize this for the SI joint? And so we block the nerves at L5, S1, S2, and S3. And it's a very simplistic block. Usually we do this again under fluoroscopy. It's done usually in my office. It can be done at a surgery center if they need a little light sedation. I think the hospital would be sort of overkill or overboard for these types of therapy. But we can utilize this injection to see whether they're a good candidate for the next step. If they get short-term relief with their diagnostic sacroiliac joint nerve injections, then we can offer to cauterize those nerves. And quite frankly, cauterizing just means that you are using a heat or a thermal lesion to provide heat to the area of the nerve or the end of the nerve to cauterize or ligate or stun those nerves. I hate utilizing burning the nerves, but if we mention burning, there's an aha moment. We all realize what burning implies. We could burn the nerve ending so it loses its ability to transmit the noxious pain stimuli into the SI joint. But essentially, you're stunning those nerves, and usually the stunning of the nerves can happen for 6 months. We hope that it would be a year, but generally in my practice, it's about 6 to 9 months. And I always feel proud to mention when I have prior attendings or colleagues that are my mentors and role models, but this was also proven by Dr. Aiden, who is one of my attendings at Hofstra, and he's proven that a meta-analysis wise, looking at a series of articles, that RFA is an effective treatment for SI joint pain at 3 months and then studying it out to 6 months. So I think we still have to get better about studying this, but it has been a proven therapy and it does work. Again, the nerves that supply it, this is a great pictorial of the yellow little nerves. L5, that nerve comes from L5 and S1, 2, and 3. And here are some further sort of articles out there to show you where the nerves come from, and the notion that if you block those nerves, that they can help with pain into the SI joint itself, as opposed to just injecting the SI joint maybe with potentially short-term relief. So everything is done sort of if something fails. And so obviously first we always start with maybe a muscle relaxant, obviously physical therapy, an anti-inflammatory. But as they progress along the algorithm, I think it's important for everyone here on listening to the talk to really understand everything from a treatment option for sacroiliac joint pain, because the last thing you want them to do is sort of not do anything about it, and get on this endless cycle of chronic pain with anxiety, depression, loss of sleep, gaining weight, etc. The things that we don't want for any of our patients. Here's how we do the ablation. So let's say they do very well with the injection. We can actually use a needle, and the needle actually has an end point. And actually, I think I may have a needle here if I'm lucky. I do not today, I'm sorry. But the needle, just think of it as a needle, and on the end of the needle, there's a little active tip. It's about 10 millimeters. It can be even 15 millimeters. And what you do is when you place the needle at the end point where the nerve would be under these X-ray images, you can actually place a stylet into the needle, and the very end point where that 10 or 15 millimeter tip is, it heats up. And the temperature we use can be anywhere between 65 and 90 degrees. And that heat provides a very good lesion to the actual nerve, but it doesn't destroy the surrounding tissue areas. And so we do this, and typically the actual cauterizing part or the ablation part of the treatment is usually about 90 seconds. And so this can be very much an in-office procedure. I just did one yesterday. If the patient requires a little bit of light sedation as opposed to local anesthetic for the procedure, we can do this procedure with light sedation or IV sedation, max sedation. So the patient's awake but not alert. And you can see how these needles are placed. kind of targeting those little yellow nerves from the prior slide, L5, S1, S2. It kind of looks like a track lesion, doesn't it? And you're kind of cauterizing all the aspects of the nerves as they make their way into the joint. Very effective therapy. For completion's sakes, when I speak to physicians, there's many ways to cauterize it, but we can cauterize around those round foramens, or those S1, S2, and S3. Or quite frankly, on the bottom of that slide, you can see we can cauterize it in a leapfrog or railroad track sign. We can just keep going down a linear strip and seeing if that helps the patient. There's many ways to do it. It's really at the discretion of the physician doing it, but there's many great outcomes that can be achieved from either or, as long as you spend the right amount of time doing it in a safe way for the patient. And you can do this cauterizing of the nerve many different ways, but conventionally what we do is we use heat. And we do a heat lesion for over 65 degrees, anywhere between 65 and 80 degrees. But there are other aspects like pulsed and cooled types of therapies. For the purpose of our talk here, I won't get into it, but if you have sort of an interest, you can read about the technology associated with radiofrequency ablation and some of the variations of the machines out there that can be utilized for patients for treatment. And again, we talked about the variation of these needle placements. So traditionally, this is our placement, and the placement is placed at those areas. And, we do this trajectory pattern. We cauterize the path of the nerves. Usually it offers quite a substantial amount of pain relief. There's other types of techniques, and this is more for your knowledge base if you want. For completion, there's some prospective case series from some of my colleagues like Dr. Vallejo, who studied this other types of lesions. Instead of heat, it's going to offer a pulsed format, which allows for heat elimination, generally keeping the target tissue not at the 80 degrees, but 42 degrees. But there's many ways to cauterize a nerve, but for the purposes of, sorry for the background noise, I'm right across the street from the hospital, so sometimes we hear that. But for the purposes of this lecture, mostly all of your physicians are going to be cauterizing with a general thermal or heat lesion. This is cooled RF, another type of radiofrequency that will allow water running through the probe tip to keep the tip cool. Again, for completion, it's here for your knowledge if you're interested. And this talks a little bit about the technique. And I think it's important for me to discuss it, because if you have a patient who's interested, I think it would be important for you to understand, what they would go through. So we use lidocaine. We numb up the skin surface. We use an X-ray. We target these 4 needles to the target source. And the first thing that I'm going to do is stimulate those nerves. It's not painful, but I'm going to ask them if they, feel sort of maybe a sensory sensation in the area where they typically have pain at their SI joint. Once we assure that we're in the right place, I'm going to actually stimulate a motor sensation. I'm going to send a motor sensation through that guide wire through the end of the nerve to make sure that I'm not stimulating the nerves that go down to the leg. So I'm going to assure that I'm not in the wrong place. Once I do that, I place a little numbing medication. I talk to the patient about their day. Usually it takes about 90 seconds or so for the numbing agent to interact. And then we go ahead and start the machine, which would allow the lesion to occur over 90 seconds. Risk profile is exceedingly low risk. Just like with any injection, bleeding, hematoma, infection, increased pain, all those things are extremely low risk. There's really not a lot of vascular tissue. Remember, around the SI joint, when we talked about those anatomies, most of them are on the side of the joint as opposed to in the back. In the back, there's really not a whole lot of vascular or neurovascular bundle that goes and causes issues with motor or weakness in the leg. So it's a quite simple injection or ablation to do for your patients. They can sometimes have increased pain for a short degree of time. Obviously, from the tissue trauma from the needles, ice is often a best friend, and sometimes they can develop paresthesia, which goes away on its own. There is some innovation involved. Instead of doing the multiple needles, there is an interesting probe that came out in 2014. I don't utilize this in my practice, but for completion, it's interesting to see these novel aspects that have developed. It's sort of like a wand, and the wand is actually kind of with a numbing agent. There's a track that's lied over the SI joint. We put this wand-like device over the SI joint through a nice little needle technique, and then we can actually cauterize the entire aspect over the course of the wand. So kind of nice things to see. Now let's briefly go over, maybe over the next 2 to 5 minutes, let's talk about, for completion's sake, some of the neuromodulation as well as some of the fusion aspects, which are more newer therapies or newer aspects. Neuromodulation means that we're going to use electrical stimulation to modulate and turn off the pain cycles that go up to the brain and spinal cord to help with pain issues. And we do this a lot for patients with persistent sciatica pain after back surgery. We do this for a complex disease called RSV, or complex regional pain syndrome, which maybe you've had some patients or clients that you've worked on before. But a lot of times we can also employ neuromodulation even for SI joint pain. And quite frankly, in my practice, I don't really do a whole lot of this because I haven't had great outcomes or success, but there are a lot of colleagues that really utilize this in their practice for SI joint pain specifically. I do utilize neuromodulation like stimulation for patients with failed back or persistent sciatica pain or CRPS, but not really a whole lot with SI joint pain. But really, you can stimulate at the level of the spinal cord. You can place some leads into the cord, near the cord at the dorsal column by introducing a needle technique. You can do a peripheral field stimulation by placing leads in between the area of the SI joint to send some signals or some transmission of signals in between the joint, just like this picture shows. There's a cluneal nerve that actually goes above where the iliac crest goes. And that can oftentimes provide stimulation to the area to kind of dampen the pain at the cluneal nerve. That can sometimes help with SI joint pain or cluneal nerve type pain in that focused area. And then there are some interesting devices that can be worn even besides the surgical approaches that we talked about with an implantable device like those leads and a battery. We can utilize even external devices, and there's some novel things out there that you can kind of search on Amazon or your vendors or durable medical equipment companies out there for like SI joint belts with maybe an internalized TENS unit to help for that type of pain. So there are things out there for completion that you should be aware of. In the last 2 minutes, I'll mention SI joint fusion. Just realize if the patients really are not getting benefit from the things that we've talked about, conservative care into injections, ablation therapies, realize that we can do things to fixate the actual joint. And traditionally, open fusion systems existed out there from first generation systems from the early 1900s. And some of the first systems were actually open, large approaches, and realized that these are great approaches still, especially for people with someone with like pelvic trauma, as that picture shows on the bottom of the middle screen. But there are some potentially newer options that have started to come about with minimally invasive dilator approach as opposed to larger incisions, and we'll kind of show that over the next minute. There are some advantages of these smaller, minimally invasive approaches. They're sleek, as just like we described with the injection. They can be done with these little dilators and little tubes, so that you can kind of look through and do the procedure that way through a smaller incision, a little 2 to 3 inch incision. And obviously, since you're doing it in the back, again, you're avoiding those arterial and vein structures that we talked about earlier, to minimize blood loss and complications. And typically their weight bearing is tolerated right afterwards. But compared to open minimally invasive, compared to open approaches that we talked about earlier, minimally invasive, of course, are going to be easier, shorter hospital stays, improved patient outcomes. And this has been proven by many prospective randomized controlled crossover trials, mainly with SI bone, which was actually a lateral but minimally invasive approach option that has great outcomes for patients. There are, because we're talking about the posterior approach, this small little cortical graft, there are limited studies right now, but there are numerous case studies or case series to prove that it works, which I'm showing right here. But prospective multi-center studies are sort of underway, and that's sort of the gold standard. And I hope that, you know, in time those will come out to fruition. But there are two that I know of to date that are both using allograft cortical bone as opposed to hardware or hardware like metal to help with that area. So, you know, realize if you're using a cortical graft as opposed to metal, less chance for infection, less chance for you know, pain. Weight bearing is tolerated right afterwards, allows for less chance of bony fracture because you're not using sort of hardware or trauma to the area that is a lot more advanced as compared to the minimally invasive approach. And then, of course, you're avoiding potentially neurovascular injury like the sciatic nerve, the arteries and vein supplies, as we mentioned earlier. So, you know, we're getting better at doing the things that we're doing from a minimally invasive approach. So I think it's important that if a patient hears about SI joint fusion, that realizes that there's so many options for SI joint fusion now. It doesn't necessarily mean that it's the traditional open approach. It might be a minimally invasive lateral approach, or it might be a minimally invasive posterior approach that, quite frankly, could be either, you know, 45-minute to an hour procedure as opposed to a 3-hour procedure. And realize they obviously have to undergo the rigors of failing everything conservatively. One would hope that they would benefit from everything that we talked about earlier, but these treatment options do exist for them should they need it. And I think it's important for us to be knowledgeable about all these treatment options. You know, lastly, I'm gonna turn it over to my colleague now, but you know, I sort of close off where if you want a little bit more information, thankfully during COVID, we tend to be sometimes proactive and do things that are fun, and I love writing stuff and doing journals and doing prospective trials in our office. So one that I wrote with my colleagues, thankfully, is this book. It's a shorter book. It's probably like 70 to 80 pages, but I think I quite frankly summarized the entire book in our lecture over the course of 40 minutes. I hope you found that helpful.
Awesome. Well, thank you. And we've already got some questions coming in here. So if you do have any questions, feel free to put those into the question box, and we will get through as many as we're able to in our allotted time. So the first question comes from Palmer, who works with the collegiate athlete population, and he asks, how early on in the treatment protocol do you suggest having an injection done? Would you do it only when rehab isn't working, or normally early on would be better?
That's a great question. I think this question really even applies to many diagnoses out there as well. I oftentimes work with my physical therapist and athletic trainers in synergy, and likewise, I can't get my job to help my patient better without you. I think likewise, if we work together, I think we can offer a more expedited approach to help heal them, both from passive modalities as well as active range of motion therapy from your aspect, as well as from an injection standpoint to help them or allow them to engage more in your sessions with you. So, I think, quite frankly, I think if you just wait the conservative time, maybe 4 to 6 weeks, by that time, they're usually in your office to begin with. And they would potentially benefit from a very simple injection, a therapeutic steroid injection, which will help them and allow them to perform better in your hands as well.
All right, and the next question comes from Alan, and he asks, do you ever use prolotherapy as a treatment option?
Yeah, it's interesting that you mentioned prolo. I was talking to someone else the other day about prolotherapy. I haven't done it in my practice. The last time that I've offered prolotherapy was in residency. I've had great outcomes with prolo, at least in residency, but I don't know why it's fallen out of favor, but I have not utilized it in my practice. But I've heard that it has worked. There are some studies out there, I think more in the case series or retrospective studies, to prove that prolo has worked for patients. I don't know what the long-term outcomes are for prolo, but I do know that there are a handful of studies out there that at least study them 3 months out. I think that it would certainly be reasonable, and I also think it would be low risk as well.
All right, so those are the current questions. If you do have any burning ones, this would be a good time to get to that.
And if there's anything else that's needed, my email address is listed there. So, feel free. Sometimes you might be shy to ask a question. I love curbside consults. I think I spend more time on my phone than I should be. But of course, I'll answer it within at least 24 to 48 hours in terms of your questions. So I'd love to answer any questions you have.
Awesome. Well, thank you to everyone for attending. Certainly we got over 100 people on here today, so I know we've got a lot of good educational opportunities for everyone. Thank you to Dr. Jassal for your fantastic presentation, and thank you to everyone for spending the time to learn with us.
Thank you all.
Have a great evening.